Hello, people, and welcome back to another episode of the Tech of Tomorrow podcast, where we believe that the real tech of the future are the humans building that future. Before we begin, housekeeping notes, remember to hit the like button if you're on YouTube, leave a comment below. If you're on Spotify or Apple or Amazon, follow the show, leave a comment, show us some love so I can keep bringing on great guests like the one I have today. Today with us, we have a longevity biotech entrepreneur who's working on partial reprogramming gene therapies for Alzheimer's disease. He's also the founder of DRASTIC Science, and he's going to explain to us what that is. He is Yuri Deigin. And Yuri, welcome to the show. I'm so happy to have you here.
Thank you very much. It's my pleasure.
How are you today?
I'm good. Good. How are you?
I'm doing great, especially now that I'm here with you. Alzheimer's is a big topic for me. Had two grandmas uh, die to it. So the idea that we could
Sorry to hear that.
prevent that or fix that is very important to me. So what do you say we start with that topic? How did you get into
Yeah,
Alzheimer's research and medicine?
yeah, absolutely. It's definitely a personal topic for me as well as my grandmother has succumbed to Alzheimer's, and I'm personally also at higher risk of Alzheimer's because I have these two copies of ApoE4 gene variant. It's a gene that kind of predisposes you to Alzheimer's. Those people who have one or two copies of this epsilon 4 variant of the ApoE gene, they actually have, well, people with two copies have like 15 to 20 times higher risk of Alzheimer's than people who have zero. And people with one copy, I think they're like 5 to 7 times higher risk of Alzheimer's. When I found out about this kind of genetic um, lottery in reverse, I became very kind of interested first in just how Alzheimer's happens and eventually in actually trying to do something about Alzheimer's or working on therapies against Alzheimer's. And here we are.
I read back in the day about the ApoE4 gene, and I've been doing some research to prepare for this show. I remember, especially back in the day, there was talks about the role of nutrition and epigenetics in the expression of the ApoE4 gene. And I remember reading that Nigerian tribes have this gene, but somehow their members seem unaffected by Alzheimer's disease. The theory made with this argument is that given that they eat a very low carb diet, those tribes, they link that to the lack of expression of the gene, and therefore the recommendation was eating a diet that's not so processed, especially low carb, could help preventing Alzheimer's disease. Is there any truth to that?
Well, I'm not like a final arbiter of truth, but in general, I think there's some um, indications that Alzheimer's could have some metabolic component. And I mean, there's a lot of research that kind of implicates the metabolic component. And some people were even, or still are, calling Alzheimer's of type 3 diabetes. Of course, there's, diabetes is known to have two types. One type 1 is the one that you're born with, that you're kind of predisposed with a genetic component. Type 2 diabetes is an acquired diabetes that you can get throughout your life if you have certain nutritional practices. Basically, if you overeat, you eat a lot of sugar, you actually can develop diabetes. So that's type 2 diabetes. And some people saying that Alzheimer's is type 3 diabetes, basically manifesting in the brain. But of course, it hasn't been like conclusively proven one way or the other. There's definitely associations between a good diet and a lower risk of Alzheimer's, and vice versa. Of course, people with metabolic issues are at higher risk of Alzheimer's. Whether you can guarantee that you're going to prevent Alzheimer's if you don't, eat a certain types of food if you have a low carb diet, for example. It's still an open question. And it seems that some otherwise very healthy people actually still kind of succumb to Alzheimer's at advanced ages. So it just seems that, of course, it's an age-related disease, and its risk is growing exponentially with age. After a certain age, I think Alzheimer's is one of the kind of rare age-related diseases where it actually starts growing exponentially after a rather advanced age, like after 50s. Before that, actually, people have a much lower incidence of Alzheimer's than, say, cancer or heart disease. But then Alzheimer's kind of starts growing and it actually overtakes cancer and heart disease in its incidence. And so it's actually growing faster. It's still exponentially, it's just a higher, kind of faster exponent than heart disease or cancer. And so from that standpoint, there just seems to be something kind of inherently tied to the aging process that drives Alzheimer's. And that's one of the reasons why we are focusing on Alzheimer's from our therapies that are in general targeting aging. The therapies that we're developing, they're called partial reprogramming therapies. And in general, they target the aging process at its core because they work at the level of gene expression. We're trying to reverse gene expression patterns or actually restore more younger gene expression patterns in the cells that we target. But ultimately, it's the aging process that we think is responsible for Alzheimer's and so many other different diseases, that if we want to prevent those diseases in the first place, going after the aging process is the most optimal solution.
Is it because, what is the reason our cells just start malfunctioning as we age? So we need to reverse that?
Well, at the end of the day, yeah, it kind of, the buck stops at the cellular level. It's the cells that do the work. Why exactly this happens and what exactly drives this pathology, whether it's some sort of centralized signaling that eventually makes it down to the cell level that changes their gene expression pattern to that's kind of less functional and eventually pathological, or there's something else that some people say there's this extracellular matrix that drives these changes. Ultimately, it results in the same gene expression pattern changes, but what's upstream of those, it's a kind of matter of debate. And we still don't know exactly why aging happens, what are key drivers of aging. We're better and better at kind of understanding the hallmarks or enumerating the hallmarks. We have by now like 13 different hallmarks of aging. But why exactly aging happens remains an open problem. And it's basically just kind of theories that people have their favorite. So people have a program theory of aging, or people have a stochastic theory of aging that's being driven by, random changes that accumulate. And maybe the matrix, the extracellular matrix, accumulates these irreversible changes and somehow influence the cells in a negative way. But I think, and basically our operating hypothesis is that within the cells, what drives aging is the pattern of gene expression. And so it's the changes in gene expression pattern, or epigenetic changes, you can say, that are really driving the pathologies that we see. And the aging process is being driven by epigenetics, and at some point it results in pathologies that the changes that occur in those cells lead to pathological conditions. And so our then kind of corollary of that hypothesis is if we intervene at the epigenetic level, we can prevent those negative changes from happening, or maybe even the reverse. If we kind of start intervening at, say, age 50 or age 60, we can maybe reverse some of the pathological processes that have occurred in those cells, in particular neurons or other brain cells that we're talking about our therapy, and prevent those conditions from happening in the first place.
When we're talking, because people have a lot of ideas when they hear reversing aging. When we talk about it, are we talking about reversing this trendy metric that's right now the biological age? Or are we talking that somebody that's 60 could start progressively looking slightly younger as their cells work better?
I mean, that's the ultimate hope and the ultimate goal of longevity medicine or geromedicine, or at least in my understanding of it, is that eventually we can reverse to some degree or to a large degree the negative manifestations of aging and actually the actual processes that drive aging, and have people start looking and feeling, most importantly, feeling and being progressively younger. So, I mean, cosmetics is just one aspect. And today you can get, pretty good results with just cosmetic surgery, but it doesn't really address the underlying problems that are driving aging and that essentially, control what really happens at the health level, and your risk of heart disease doesn't go down if you had a cosmetic surgery and you look 20 years younger, but underneath it's kind of still the same machinery that's going to, potentially have you at risk of a stroke or heart attack or cancer. But ultimately, as a longevity therapy, systemic longevity therapy that applies to the entire organism, the goal is to actually reverse all these processes and make you be younger, and hopefully progressively younger as treatments improve and we get better and better treatments that actually go to the core of the aging process. But of course, right now, and we can do this at the cellular level, by the way. This is what started the whole partial reprogramming revolution, is that we were observing that at the cellular level, the reprogramming process reverses all of these cellular hallmarks of aging, and it makes an old starting cell, a young reprogrammed cell. And this is what inspired people like Alejandro Campo and his PI, Juan Carlos Espeso Belmonte, to then try to apply this reprogramming process at the level of in vivo, like animals, already formed animals, and trying to see, can we harness some of this rejuvenating aspects of reprogramming to be applied to already formed organisms. And so this is what we're trying to achieve. And this kind of reversal of aging being our ultimate goal, at this point, of course, we want to first see if we can just slow down the aging process by periodically bringing back this gene expression pattern to a more youthful level. Maybe we can at least slow down the irreversible increase in risk of mortality and all other negative processes that happen with aging. But ultimately, yes, the goal is to be able to reverse these processes and make people, or humans, animals maybe as well, younger, biologically younger, and reduce the risk of disease, improve their health, and to have true rejuvenation, basically become a reality.
You mentioned the hallmarks of aging. What are they?
It's basically just as the name implies, manifestations of aging, different manifestations of aging that we see, from like cosmetic wrinkles, gray hair, less hair falling out, to the kind of organismal level, shortened telomeres, stiffened extracellular matrix. This is one of the kind of newer hallmarks that's being kind of popularized right now, and maybe underappreciated hallmark of aging that in the years past wasn't looked at as closely as it is right now. And basically, yeah, things that happen on the cellular level, you get more DNA breaks, double-strand DNA breaks, or actual symptoms of DNA breaks, like markers on the DNA suggesting that breaks have happened, or like repair machinery in the DNA indicating that a lot of breaks have been happening. The nuclear envelope, the envelope that surrounds the nucleus, becoming worsened, it becoming worse and worse. Things accumulating inside the cell, like protein aggregates, and so many different things that have been enumerated over the years that by now, I think the accepted number of hallmarks is like 13 different categories of the hallmarks of aging. And yeah, so basically manifestations of aging.
What are the stiffened extracellular what is a stiffened extracellular matrix, and how does that affect aging?
Well, that's an open question how it affects aging. There's some theory that's saying that progressive stiffening of the extracellular matrix can actually be driving aging, or some aspects of aging. And it comes back to this kind of cross-linking of the matrix, which makes it stiffer. So this, like, softness and stiffness are like two opposite I guess processes or qualities of a particular mechanical system. And so we have basically extracellular matrix is where the cells live in a nutshell, right? So we have our cells, but the cells, they don't exist in a vacuum. They actually inhabit this rather structured space where collagen proteins and other proteins and elastin proteins are actually creating this living space for those cells where those cells operate. And in different tissues, of course, have different characteristics. Some matrices or extracellular matrices or tissues are stiffer, some are actually softer and more sparse for kind of processes, intracellular processes to like occur basically between cells, intercellular processes rather than intracellular processes. Intra basically what's inside the cell, and inter the processes that happen between the cells. And with age, all these components of the matrix can have the kind of irreversible changes, random changes that occur to them that stiffen this matrix, like cross-linking of this collagen proteins, for example, can happen because of some non-enzymatic, non-reversible changes that happen just as in the course of the animal's life. And some proponents of this matrix theory of aging say that it's because of these irreversible processes that the matrix becomes stiffer, and this somehow influences the cells inside that stiffened matrix to recognize this and start behaving in a progressively worsened or older fashion. And so this is one of the ideas of one of the aging hypotheses, that aging is primarily driven by these non-enzymatic changes, in particular the changes to the extracellular matrix.
So basically the cells become less efficient at doing what they do because there is this stiffening happening?
Yeah, and I guess one of the actual corollary of this hypothesis is that the cells are actually fine and can reverse their behavior if the matrix becomes somehow less stiff, or if you actually take those cells, transplant them to a novel matrix, less stiff matrix, or younger matrix, the cells recover and start behaving as if they're young cells. And this was actually demonstrated in a couple of papers that I think had some sort of methodological issues, because they really took like progenitor cells and proliferating cells. One of them was a oligodendrocyte progenitor cell, one of the papers that kind of which the result of that paper established this narrative that you can take an old cell from an old matrix, transplant it to a new matrix, and it will become young again. And the way they assessed this youthfulness is its proliferating capacity, and mainly its proliferating capacity, actually. But of course, progenitor cells, their entire job is to proliferate. As, for example, young brain oligodendrocytes are part of the brain cells, and which myelinate, axons. But their job is to proliferate, and actually the stiffness of the matrix is one of their signals telling them to stop proliferating. Basically, it's one of the kind of mechanosensing apparatus of the cells that they actually need to stop proliferating if they detect that the stiffness has increased to a large degree, which usually means that surrounding cells are already, there's a lot of surrounding cells. And so, of course, if you then transplant them to something that's less sparse, then they kind of restart their original program of proliferation. And this is not necessarily a sign of that they've been rejuvenated. It's just a sign that they're now just, fulfilling their inherent program of proliferating and differentiating into actual oligodendrocytes. And so taking that as or extending that finding to saying all of the other cell types that are not proliferating cell types, a lot of cell types don't proliferate anymore, can be rejuvenated by just transplanting them to a younger matrix or making the existing matrix less stiff. To me, it's not really a valid corollary of the observations that were reported in that paper on the oligodendrocyte progenitor cells. I actually hope to one day put out actual paper on this. I have a draft of it, basically kind of arguing with this very extension of the results to mean this very, very kind of popular concept now that, the matrix is what's driving it, because if you take a cell from an old matrix and put it in a young matrix, that cell is rejuvenated. Well, the rejuvenated cell, I think, based on this oligodendrocyte progenitor cell, is not a valid claim. in my book. So hopefully one day I'll actually publish it.
Looking forward to that. We
Yeah, we
may,
got on quite the tangent
yes,
on investigating
but there are
the
these terms that
ECM.
are trendy right now, and we could probably expect this Stephen extracellular matrix to become something we hear more about. Another term is telomeres. If somebody's completely new to this thing into anti-aging, and a lot of people are getting into it, what are telomeres? Because that's something you will almost immediately come across as soon as you get into the anti-aging space.
Yeah, and I think actually most people, when they hear aging, telomeres is like the next thing that pops up in their mind. This has been like very well established from like a marketing standpoint, this kind of top of mind uh, reaction to like association. You hear aging, the telomeres is one of the first things that the general public associates with aging research. And telomeres are these caps at the ends of our chromosomes, or like these sequences at the ends of the chromosomes that some people say are just like a protective cap at the end of the shoelace. It's the same for our chromosomes, and basically protecting our chromosomes from some sort of degradation when we are copying our DNA. Because when cells are proliferating and the DNA is replicated, the existing machinery that replicates DNA for some reason cannot replicate it fully. So it actually stops a little bit short of the end of the chromosome. And so to avoid missing information during this copying process, evolution has come up with these telomeres, which basically are kind of useless bits of like non-coding, non-informational bits of the chromosome that basically you can sacrifice with each subsequent copying of the DNA or subsequent cell division. That if you kind of don't copy the whole sequence of telomeres, that's okay. Nothing bad is going to happen to the cell. The genes, the informational content of the genes remains intact. But at the same time, of course, evolution has also come up with the machinery to elongate telomeres at some points where basically they become too short, to the point that you're risking that on some subsequent cell divisions that you're actually going to not copy enough of the actual coding sequence of the gene. And so you have telomeres that prevent basically this from happening. And you have this special enzyme called telomerase, which can lengthen telomeres pretty much at will. And one of the kind of early aging hypotheses popularized by Leonard Hayflick, who passed away recently, unfortunately. And basically the Hayflick limit is this popular term that a lot of people associate with aging. It was a kind of telomere hypothesis of aging, that we age because our telomeres shorten, and for some reason we can't lengthen them any longer. And the Hayflick limit arose from this experiment in a cell culture where they kind of kept inducing these cells to divide, and noticed that there's a certain limit after which the cells just don't seem to divide anymore. And this was termed the Hayflick limit. Basically, after like 50 divisions, 50 consecutive cellular divisions, doublings or cellular doublings of the culture, the cells stopped dividing. And when they investigated basically why, they realized it's the telomeres in those cells that do not get lengthened, that's preventing then the further replication of those cells. Because the cells that we're actually looking at, they were in those cells, telomerase was not active. Telomerase is actually limited to only a certain population of stem cells, which are normally the highly proliferating cell types that actually need telomerase to be on to avoid the problem of telomeres actually stopping the functioning of the cell types. But the problem, of course, for the telomere hypothesis of aging is that most of our cells in our body never actually reach the telomere limit for division. So, and in many other experiments, the telomere hypothesis of aging was shown to be invalid. Basically, we do not age because we run out of telomeres. And of course, we also have telomerase that when needed, can elongate telomeres without any problems. But for some reason, kind of the in the popular science or popular mindset, the telomere hypothesis aging has stuck around because it's a very simple explanation, and I think we as humans always like simple and elegant explanations that if we only lengthen telomeres we can live forever. Unfortunately, that aging is not as simple. But hopefully, I was able to kind of explain what telomeres are as kind of a primer on the telomere hypothesis of aging.
Yes, that was great. Now, back to what you do is gene therapies and partial reprogramming. So, do you want to start by gene therapies or by what partial reprogramming is?
Yeah, I think partial reprogramming, kind of explaining what that is, would be a better progression of getting to why we actually need gene therapies to deliver partial reprogramming therapies. And so partial reprogramming is using cellular reprogramming in a partial fashion, where cellular reprogramming is this concept or this process that was discovered by Shinya Yamanaka and his postdoc Takahashi in 2006, where they found the combination of certain genes, certain transcription factors that can reprogram cell all the way back to the ground state of organismal development, basically called embryonic stem cells or pluripotent stem cells. These are the stem cells. Embryonic stem cells are the kind of the root of the tree of all our cell types. All of our cells in the formed organism have come from this small population of embryonic stem cells. And until that experiment, people thought, or kind of the dogma in biology was that differentiation, or this kind of the lineage of cells, is a one-way process. Basically, you start as an embryonic stem cell, and this subpopulation divides, and then whatever cell type you end up as is your irreversible. Basically, your skin cell can no longer return to this ground state of development, to this embryonic pluripotent stem cell state. But Takahashi and Yamanaka have proved it wrong, and they conclusively proven that actually cell lineage, cell differentiation is a two-way process, and you can go all the way back to this ground state and become, again, this pluripotent stem cell from which, in theory, you can grow again the entire organism, your twin, if you like, your clone. This was, of course, a groundbreaking discovery, and they were given, Yamanaka was given the Nobel Prize, as often happens. It's the PI that gets the Nobel Prize. In 2012, he got the Nobel Prize. And the interesting, or the very important observation for our field, for the longevity field, was that during the reprogramming process, and I mentioned this in the beginning, it actually turned out that the cell is also rejuvenated on the physiological level. All of the hallmarks of aging, the cellular hallmarks of aging that you see in an old cell, after the reprogramming process, are somehow ameliorated, and you end up with essentially a new, very young looking, physiologically young reprogrammed cell. And this is what inspired all of the scientists in the aging field to then wonder, how can we kind of seize this rejuvenating magic, harness it, and apply it for our very selfish benefits of rejuvenating already formed organisms. And I think it was understood or hypothesized that this is really the process that enables old animals, old humans, to have a new baby every time. This rejuvenating magic that happens in the embryonic stem cells is actually what keeps subsequent generations to be able to continue and avoid the aging that happens in their parents. And potentially this is what now we're trying to harness in the reprogramming process, this kind of rejuvenating power that nature already has built into our biology, but only reserved for reproduction. We're trying to kind of hack it away from biology and to be able to apply it to our already formed and aging organisms and maybe rejuvenate these organisms and essentially keep having this kind of fixed level of health or biological age that aging process cannot then, or at least slow down the aging process, that our deterioration of our organism is not as quick as it currently is.
So
yeah, so I guess and that then of course the partial reprogramming aspect of it stems from people trying to use the full reprogramming approach in vivo in the context of already formed organisms, and eventually figuring out that you actually need to use it in a partial fashion. So the first attempt at using reprogramming, at using cellular reprogramming in vivo, came in 2013. It was a group by Manuel Serrano, who was in Spain at the time. I think it was either University of Barcelona or CNIO, the Cancer Institute. Yeah, basically Manuel Serrano, he's now in Altos Labs, actually, the biggest reprogramming company and the biggest longevity company ever with their $3 billion. So in 2013, his group tried to induce these reprogramming factors that are called Yamanaka factors, based on the Shinya Yamanaka, who got the Nobel Prize for their discovery. And so what they tried in 2013 was just to create a transgenic mouse in which you can induce those reprogramming factors at whenever you wanted to. So they put those factors basically into the cell's DNA, but they were by default silent, but you can activate them by giving those mice a small molecule, doxycycline, for example, one of the molecules that can activate the expression of these factors. And so they tried this in 2013. Basically, they took these mice, waited for a certain period until they become, adult or older, and try to see if they can rejuvenate them, and started activating those Yamanaka factors by giving that small molecule to the mice and trying to see basically what happens. And what happened was those mice died horrible deaths within 2.5 weeks. And so the title of that paper was actually very gloomy, basically something along the lines that in vivo reprogramming causes teratomas and cells with totipotency features. Something basically that if you read the title of that paper, you would never try partial reprogramming ever in a live animal anymore. But thankfully, there was a group at the Salk Institute in the United States, a group of Juan Carlos Espiso-Belmonte and one particular postdoc in that group named Alejandro Ocampo, who actually started trying a similar approach even before that paper came out. And so he decided to try basically first seeing what is the safe duration for inducing these reprogramming factors before mice actually start dying. Because in that paper, in the 2013 paper from Serrano group, I think they went for like 2 weeks, and after 2 weeks they saw mice die. And Alejandro Ocampo used a different mouse model, also transgenic, but a different mouse model. And basically his first step was to figure out when do mice start dying, and to try then to induce those factors only for shorter durations than that. And he discovered that basically mice, that particular model started dying after like day 4 of induction, or maybe day 3 of induction of these Yamanaka factors. And he decided, okay, why don't we try just inducing Yamanaka factors for 2 days at a time, and then giving the mice time to recover, and then rinse and repeat. And so based on that methodology, they were able to then figure out a safe duration of this expression of Yamanaka factors and the safe protocol, basically 2 days of expression, 5 days of washout period, like no expression of Yamanaka factors, and in a repeated manner. And when they tried that in a mouse model, they observed, first of all, that they can do it safely, no teratomas, mice not dying, and actually mice were living longer, functioning better. And when they then, examined all the mice that have died, they figured out, they observed the like better biomarkers and better tissue histology, better functioning, like they have fewer senescent cells, better mitochondrial function. And so overall, this is what gave rise to the entire partial reprogramming field, because they've discovered that if you induce reprogramming partially for short durations, then you can do so safely, and you can also get the rejuvenating benefits of reprogramming. And this was the kind of watershed moment for the entire field, and this is what essentially started, the entire partial reprogramming field. And then subsequent groups have tried to replicate those findings. They replicated those findings. They observed lifespan extension. They've observed also various therapeutic benefits, like improved tissues, improved functioning of several systems like cardiac function, for example, mitochondrial function within cells, etc. And by now, there's been probably 24 different studies in which some sort of therapeutic benefit was observed as a result of induction of partial reprogramming in various different disease models. And so I guess this brings us to gene therapies. Why do we need gene therapies to deliver those reprogramming factors to first mice and ultimately into humans? Basically, we need to, because we are already formed organisms, we can't become transgenic like those mice, in which they can insert whatever genes they want before they're born. Well, we're already born, so the only way we can insert those genes or activate those genes in our cells is if we deliver those genes somehow into our cells. And you can deliver those genes as mRNAs, or you can deliver those genes as DNA. Both can be considered gene therapies, but the gene therapy using DNA, you can have some constructs that you deliver only once, and then you induce those constructs on a on-demand basis, where when you want to activate those whatever you've inserted. And so if we're talking about Yamanaka factors, the construct that we're using is formulated in such a way that by default it's silent. If it gets into your cells, it's silent until you give the patient the activating molecule. And when you give that activating molecule, again, doxycycline as the first generation therapy is going to have, that starts the expression of these rejuvenating genes. And so we can then activate those genes for like 2, 3, 4 days at a time, and then stop. And then basically this very same methodology that original Ocampo paper used, with maybe a little long duration, but basically periodic induction of rejuvenating factors with a washout period that follows. And you can do this in a repeated fashion, and with the expectation that this will lead to therapeutic benefits in the cells and the tissues that you target. So this is our modality. We're applying it to the brain, and we're applying it to other tissues as well. And also, one of the things that I should also mention, that during the course of research into the reprogramming process, one of the questions was, okay, why do mice start dying if you keep inducing Yamanaka factors? And it's not the teratomas that kill the mice. Teratomas are these tumors, basically, these tumors, not necessarily high, not necessarily invasive tumors. They don't have high metastases, but they look not very nice, especially like if a mice dies and you start analyzing its tissue, you have these clumps, these tumors that form. But that's not actually what kills the mice. What kills the mice is loss of function of particular organs that are like the weakest links in the chain of whatever our organismal functioning. And those two organs were then established by, again, Alejandro Campo later, when he already got his own lab in Switzerland, in Lausanne. He established that it's the liver and the small intestine that are the two key organ systems that start failing, that they actually fail first if you keep inducing Yamanaka factors for continuously. And then he also showed that if you avoid just those two organs, if you just avoid the liver and the small intestine, then the mice in which you formulated, basically transgenic mice in which you formulated induction to avoid those two tissues, they live much, much longer, like 2.5 times longer, from 4 days to 10 days of consecutive Yamanaka factor expression, if you keep inducing Yamanaka factors continuously. And so this necessitates, in our view, and I think in the view of Alejandro Campo as well, this necessitates that partial reprogramming really needs to be tissue specific. So there's some tissues that you have to avoid those loss of function that can be, lethal to the animals or to humans. And so the best way, in our view, to then create therapies for partial reprogramming is to have tissue specificity built in. So basically, you start with a specific tissue that you only activate reprogramming in that particular tissue. And then once you've established the safety and efficacy of the therapy that targets that tissue, say the brain therapy, and then other tissues, say, I don't know, your kidney therapy and muscular therapy and cardiovascular therapy, then you can combine those therapies into one, systemic therapy that targets multiple tissues. But until then, you shouldn't have constructs that target multiple cell types, because this can lead to detrimental side effects, in particular the liver. As gene therapy, the liver is the organ where gene therapy ends up ultimately, because bloodstream goes through the liver. And so actually, we want to avoid expression in the liver in the first place.
So how do you deliver?
And so,
mice have died horrible deaths because they.
well, not horrible, I guess I was like a little exaggerating, but yeah, they did succumb to liver failure. Liver is the first organ that causes the death in those animals if you keep inducing immunogenic factors for too long.
How do we know it will work the same way in humans, and how do we know which organs we cannot? How do we know that it's the liver also in humans that we cannot touch with the gene therapy? Or will we not? Do we have to fuck around and find out?
Well, I wouldn't, I wouldn't want humans to, but I mean, we have very similar. I mean, mammals have very similar organismal functioning, at least when it comes to kind of basic metabolism and function of the organism, that we can pretty confidently extrapolate results in animals to the results in humans. I mean, this is the foundation on which drug development is built. That's why we test in animals first, and then the results in animals we would then take to be as kind of illustrative for purposes of what to expect in humans. And so if we see a drug causing liver failure in mice, we then can, like with 99% probability, expect that it will also cause liver failure in humans and other mammals. It's unfortunately vice versa. Like the positive stuff does not necessarily translate. So if we can prevent Alzheimer's in mice, that doesn't guarantee that we'll be able to prevent it in humans. And this has been kind of the Achilles heel of Alzheimer's drug development in general. There's so many therapies that have produced therapeutic benefits in mouse models, unfortunately, but they didn't translate into human positive kind of effects in when they were tried in clinical trials, like in large clinical trials. But of course, you can at that point start going into like the details how good actually Alzheimer's mouse models approximate human disease, because normally mice, unfortunately for our purposes, for drug development purposes, unfortunately, mice don't develop Alzheimer's. So we have to concoct these kind of transgenic mouse models that try to approximate this pathology by like flooding their brains with beta amyloid, for example, and observing kind of similar symptoms as we observe in humans. And then, of course, the therapies that then all target this beta amyloid and produce very nice effects in mouse models, when we then try to study them in humans, or not we, but like in general, the drug development field, which has been kind of obsessed with the beta amyloid hypothesis, when it tries to use drugs that are based on this hypothesis, then in humans, the results have not been as good as in mice. Although, of course, by now we do have 2 approved drugs, antibodies that target beta amyloid, that have produced some clinical efficacy in human patients. So I guess, it's not terrible. It's not good, but not terrible.
I remember reading about the beta amyloid hypothesis being either extremely flawed or disproven. How much truth is there to that?
I wouldn't call it neither extremely flawed nor disproven. especially as I said, given that we have two approved drugs based on the amyloid hypothesis that directly target beta amyloid, those antibodies, they target beta amyloid. And I think one new result or a newfound understanding of the amyloid hypothesis is that you actually need to start targeting beta amyloid very early in the life of a patient. Basically, before when human trials tried anti-amyloid therapeutics, the problem was that they were too late. Like if you actually hope to target beta amyloid and get a reversal in a patient that already has Alzheimer's symptoms, that's probably not going to work. But if you target early enough beta amyloid in people who maybe don't yet have Alzheimer's symptoms or have very mild cognitive impairment, then you might actually succeed in slowing down their cognitive decline or getting to an Alzheimer's diagnosis. The problem, of course, is that the effect is very small, even for approved drugs. Like the difference in reaching certain milestones is on the order of like half a year. You kind of slow down the degeneration by half a year in those patients on average, which may not be all that great. Although like it's all relative. Like if you look at the cancer field, a half a year increase in life expectancy is considered a very, very positive result. So it's really a matter of expectations. But on the flip side, obviously, beta amyloid is not the ultimate, really, like end all and be all, like the cause of Alzheimer's. That much we know. So there's a lot of more intricate, I guess, aspects to Alzheimer's etiology than just beta amyloid. So from that standpoint, you could maybe, you could say that it's not like if your claim is beta amyloid is the cause of Alzheimer's, that's not an accurate statement.
A lot of people get concerned when they hear the term gene therapy because messing with the DNA because they
Well, yeah, a lot of
get
people.
concerned. So what do you think about that? How do we make that more accepted or more understandable to the common person?
Well, I mean, it's really, like a matter of educating people, and I guess there's different kinds of gene therapy, and some are more scary, some are less scary. And again, it's all relative. It's scared compared to what? If it's scared to getting Alzheimer's and kind of losing your cognition in a matter of a couple of years or 3 or 4 years, once already the symptoms manifesting themselves, maybe it's not as scary. And obviously, as any therapy, we need to prove that it's safe. And of course, the problem in general with long-term treatments is that some side effects might only start manifesting themselves years or decades down the road. But if we're talking Alzheimer's, again, this could actually be much better if we have some sort of side effects in 20 years of starting the Alzheimer's gene therapy. That's actually a good problem to have, because if you didn't use this gene therapy, you'd be dead from Alzheimer's in 10 years. So there's always you have to do a risk-benefit analysis for any therapy, but of course for therapies against such terrible diseases as Alzheimer's might have a little more risk tolerance, I would say. And again, it's the patients who are willing to try these therapies, they usually already are at a point, I wouldn't say have nothing to lose, but it's actually quite close, because, as I said, even the 2 approved drugs have very slim efficacy. And so if you're an Alzheimer's patient whose only prospect is to, lose your cognition and lose your memory and essentially, basically not cease being the person that you are within a time scale of a few years, and you have this potentially risky therapy that could maybe give you many more years, or could potentially, kill you. Of course, the ultimate risk. It's the decision that, many people might actually take. The risk of, dying from Alzheimer's in, I don't know, 3 to 4 years if you don't try it, versus the benefit of potentially being in good cognition for decades versus, of course, the risk. And of course, the only necessity is to make sure that the patient understands all those risks. That's why it's called informed consent. The patient needs to be fully informed what exact risks he or she is subjecting themselves to. So as long as they are made aware of it, yeah, it's their decision to make. In terms of the general public, again, yeah, we're not. I mean, we're not in the business of educating the general public. There's probably like other people who can do a better job. Our job is to develop these therapies, and then ultimately, if the patient wants to try it, they will. And right now, like the therapies, available therapies, the two approved therapies have a lot of bad side effects with like brain swelling and bleeding, and up to like 40% of, from what I remember, patients actually experience some of these side effects. And so, I mean, yeah, unfortunately, the state of the current Alzheimer's clinical standard and clinical need is such that there is a high unmet clinical need that Alzheimer's patients need. And in terms of like cumulative potential suffering of people who have Alzheimer's or might develop Alzheimer's, it's a huge problem because it's millions and millions, tens of millions of people now, and it's only going to get worse.
So besides unproven nutritional interventions and given the fact that one cannot take the current therapy available drugs in a preventative way, what could a normal person do if they want to reduce the chances of developing Alzheimer's? And we're talking here just lifestyle implementations. So is there anything?
Well, I mean, yeah, there's like people say lifestyle intervention, something that we talked about in the beginning in terms of your like metabolic risks and reducing metabolic risks. And there's some lifestyle things that are associated with more or less risk of Alzheimer's. You can try that. There's some supplements people take, but in terms of like guarantees or any proven interventions, I'm not aware of anything that is actually like has been clinically proven to reduce risks of Alzheimer's. There's a lot of people trying things and some anecdotal things, and there's some kind of support groups. There's like an ApoE4, a whole community of people trying different things and trying supplements and trying things like taurine or, alternatives to taurine and some things that have been tried in clinical trials, but maybe haven't had widespread success, but people still use them as kind of on a biohacking, under biohacking umbrella. But in terms of, yeah, like something that you can point to and say, okay, if you don't drink or you don't smoke, you're gonna, reduce your Alzheimer's chances by like 2 or 3 times. I don't think we have anything like that we can point to.
I have been under the impression in the last years that the more time goes by, the more we hear of people getting Alzheimer's. Is that a function probably of the fact that our average age, like it keeps getting further? We get older, so we develop more Alzheimer's, or is there really more and more Alzheimer's for factors we don't understand?
Yeah, I'm not sure. I don't think there's any, at least to my knowledge, data that Alzheimer's somehow became more prevalent for a particular age group. Alzheimer's, yeah, it has a very strong age-related component, like exponential rise in risk. There's like, yeah, by age 65, I think there's 5%, and by age 85, there's like 12% of all women and 10% of all men have Alzheimer's. And if you have ApoE4, two copies of ApoE4, it's 60% of all women and 50% of all men. So half of all men with ApoE4, 2 copies of ApoE4, get Alzheimer's, and 60% of women. So yeah, like the more, and of course people live longer and longer on average. A lot more people get to advanced ages, and so that's why we see more people with Alzheimer's. And maybe also we got like better at diagnosing it, and at least based on like some non-invasive imaging that now that have been developed, or blood tests. You get more diagnosis, or like more higher certainty diagnosis that the dementia that they're exhibiting, or the symptoms of dementia that they're exhibiting, is actually Alzheimer's rather than some other form of dementia. And before, yeah, like diagnosis of Alzheimer's has been improving and over the years. So it's also could be that reason. That's the reason why we hear more and more about people with Alzheimer's being diagnosed.
Do you think that how do you see the future of anti-aging medicine, biohacking, and gene therapy playing a role in the fact that in the West, our populations keep getting older and older, our birth rates are plummeting. So is anti-aging something we need to keep people active for longer, even in the workforce? How do you see the future playing out in this regard?
Yeah, I think absolutely. I mean, yeah, longevity interventions and longevity therapies are absolutely essential to even, outside of any current contexts, in general, people's health and life should be our first priority as a society. And if there's anything we can do to give people longer and healthier lives, we should be doing it. And fertility, and of course, that's for like governments to be incentivized to now invest more into longevity research is one of the reasons. Yeah, like fertility rates plummeting. And so if they want to avoid depopulation, they need to really figure out quickly how to keep people alive for longer and healthier for longer, and hopefully fertile for longer. And it's funny because overpopulation is probably the biggest retort that lay people have when they first hear about, let's find ways to live longer. They say, oh, but what about overpopulation? And more and more now, you actually stopped hearing about overpopulation because more and more people are concerned with depopulation. As things stand right now, we're actually facing the risk of depopulation. Definitely in the developed countries, it's already happening, and worldwide, at some point, I think we'll start seeing the depopulation because people just stop, for some reason, very precipitously stopped having children. But yeah, I think it's a public health concern, number one, how to make people live longer, healthier lives. And how do I see progress in the field? I think actually we are at really an inflection point with AI. I know everybody's an AI expert these days, but I think like observing the progress of the past year of how good language models or other models like these AI systems have become in terms of biology and their knowledge. I think we are actually very quickly going to have AI systems that surpass our understanding of biology, and also they'll be able to design experiments and they maybe even conduct those experiments using some sort of like automated lab processes that will be able to answer questions that we as humans haven't been able to answer up to this point of what exactly is driven, like how exactly is aging driven, and what exact processes we can intervene at to actually stop or maybe reverse the aging process. And maybe these AI-driven systems will be able to figure out ways of come up with novel interventions that we have even never thought of and implement them very quickly. So I think progress in this field, both in terms of longevity field and AI-driven longevity field, in the next decade or two, I think is going to be very, very impressive.
Are you using AI already in your company?
I wouldn't say it's AI. I mean, we definitely use ChatGPT for some question and answers, but we use bioinformatics tools for some of the data analysis that we do in terms of for example, our search for novel reprogramming factors. There's a lot of data and gene expression data that we're analyzing to find candidates for these novel factors, and we use a lot of, I guess, bioinformatics tools, and some of these can be classified as machine learning tools. So, and AI, I guess it's kind of the previous generations that you can always claim this is AI, and there's this famous caricature where, to an investor, it's AI, and to, I guess, bioinformation, it's machine learning, and to, I guess, down the line is just linear regression, right? The
Yes,
next level.
statistics.
Yeah, yeah. So, but I think, yeah, going forward, there'll be more and more like actual AI tools that could be classified that they're actual intelligence, rather than just yeah, statistical methods.
Is there any recommendations would have for somebody listening that wants to go about slowing down their aging, dietary interventions, proven supplements? Is there anything like that that you believe in, or that at least you have seen that actually produces results? Because I've seen NAD therapy shorten your telomeres, but again, we talk about telomeres and how they're not like the pivotal factor. So is there any way for the normal person to start thinking about aging slower without, given that we cannot just go and have a gene therapy right now?
Yeah, I mean, there's nothing that I think can really, at least to my knowledge, slow down your aging. There's things that can speed it up that if you avoid can probably, give you a few more healthier years to wait until like really cool interventions are being developed from the gene therapy side or any other side. Who knows, maybe the brain-computer interface will be the first to completely solve aging, like in a very, very different way that we don't even need to then figure out the biology if we can just kind of circumvent biology. So, basic stuff is like don't smoke, don't drink too much, watch your weight, and uh, don't drive a motorcycle, those things. And of course, exercise, yes, it's very, very helpful as just kind of preventative aspect. Some people like sauna. There's a lot of associative data from Finland that people that use a lot of sauna have a reduced risk of cardiovascular events and all-cause mortality. Whether that's actually like an intervention or just kind of the causalities backwards, that kind of healthier people tend to use sauna more and are able to tolerate 4 to 7 times a week of sauna for like 20 minutes. It's still an open question in my book, but some people have actually been kind of taking those data and using it as causative data. I'm not aware of any interventional testing that you take random sample of people and assign them to like a sauna group and some sort of like non-sauna placebo group and actually test that there's actual value in using sauna. But at the same time, sauna, at least to my mind, is safe enough to be doing it anyways. So I think from a standpoint of it couldn't hurt. I do it. I like sauna, but I don't get to do it as often as I used to or I'd like. But if you're able to, I think it could be a good thing to be doing for just general healthy purposes. Sleep, of course, people have gotten obsessed with sleep like over the past couple of years. I think Brian Johnson has been popularizing. Between that and his erections, I think that's his biggest sleep is the favorite topic on Twitter that he's been preaching about. So, and a lot of people are, there's definitely a lot of potential problems that lack of sleep can cause. Whether normal sleep can, do anything extra is an open question, but definitely try to at least get enough sleep not to get into some sort of health problems that lack of sleep can cause.
Sleep,
So, I mean,
sleep is important when it comes to Alzheimer's too, right? Flushing out the beta amyloid accumulation, everything.
that's
If I,
the hypothesis. Yes.
that's
Yeah. Like there's a lot of these kind of narratives that, oh, like, yeah, during sleep, your brain kind of cleanses itself and the lymphatic system kicks in. And if you sleep 1 hour less, that somehow like it doesn't have enough time to clean that stuff out. And maybe it's the deep sleep period in which only the cleaning happens. These are all like, as I said, there's a lot of unproven narratives, but have become kind of very popular because they kind of speak to our need for simple explanations. And I think this is kind of one of these narratives that, and again, it's harmless. Like, why not sleep more? Try to get as much good sleep as you can, beyond point of pathological. Don't stay in bed for like 12 hours. There's also like this Goldilocks zone for that. But yeah, I think we should be careful as not to kind of get into this trap of convenient narratives.
If you were to make a prediction, how many years away do you think we are from understanding aging? And how many years away do you think we are from, let's say, slowing it down before we say reversing it?
Yeah, well, I think it comes down to how many years we are away from like truly intelligent AI that can unlock biology and fully decipher all of the biological processes, or at least the ones that are important to aging. And I think we're quite close. I think, yes, basically we need to get to the level of understanding, AI understanding that will be able to design experiments that will answer those key questions and conduct those experiments. And I think, you can conduct experiments relatively quickly in model organisms and even in mice. You can do it, 1, 2 years if you use pre-aged mice. So, and of course, designing interventions and then figuring out how to intervene. Once you fully understand aging, I think it'll be, again, quite quick till we are able to intervene effectively in this process, in those processes. And so I think, yeah, within a decade or two, we'll get to the level. I think within a decade, we'll get to a really very deep understanding of aging, maybe fully understanding aging with the help of AI. Humans, I think we're hopeless. Like our intelligence is just not up to par. But AI, with its rate of progress, I think within a decade, it will unlock and decipher how exactly aging happens. And maybe even in parallel in that decade or within another decade, it'll come up with interventions that can effectively slow down, very effectively slow down, maybe even reverse aging. But at the same time, I think by then it'll be a moot point because there'll be other ways that we can circumvent aging, circumvent biology, that we might not even need those interventions.
What do you think about stuff like Neuralink?
Exactly. Well, this is what I mean. Yeah, I think we'll have brain-computer interfaces that, coupled with, I guess, research into external consciousness, basically will allow us to start slowly inhabiting or moving our consciousness to non-biological substrates, where at first it'll be just seamless kind of integration with brain processing outside of our brain, basically, or brain-like processing, that more and more, I mean, already right now, like brain-computer interface as it's envisioned right now, will give you the ability to, first of all, store extra information and access it. Like right now, you store stuff on your iPhone and you access videos and photos and whatever. And also in the internet, brain-computer interface, kind of the first version for healthy people, will allow you to basically have seamless integration with audio visual processing, memory, and also like actual computer essentially inside your brain, and internet access, like infinite knowledge. But as a next step, I think it will allow you to actually start mental processing, outsource your mental processing. And as you get like over and over longer and longer periods, essentially you'll have a lot of your mental processing start being done progressively outside of this meat brain of yours. And at some point, I think we'll be able to transfer most, if not all, of our personality to this external brain, that essentially our personality will no longer be limited by just kind of this substrate, but this will be just one, maybe small part of who we ultimately become. I view it as kind of this next level of growth and organismal development. As like, for example, like I think the example I use is remembering our growth from when we were a child. Because a lot of people say, well, this won't be you anymore. And I say, well, are you the same person? Oh, Siri, why? Are you the same person as you were when you were 3 years old? Clearly not, but you feel it's still you. It's just you've kind of grown, advanced version of yourself. And this will be then kind of next stage in our growth and development. That ultimately, of course, it'll be a very different creature, but still, I think this will be you will feel as if it was still yourself. And this is kind of compared to the alternative of just dying and ceasing to exist. That alternative, I think, is more preferable to a lot of people, and definitely something that at least worth trying. And maybe, if at some point you are dissatisfied, you can probably go back to your fully just exclusively biological self.
Then we enter the philosophical, right? Consciousness and all those ethical and even religious matters that come into mind when we talk about transferring in and out your personality to a computer interface.
Well, I mean, I view all those things as really, and fluff is probably a little bit, a impolite way of putting it, but I think these are like ultimately we are only limited by biology and physics, and everything else is our social constructs and things and ethics and religion, the things that we invented over the course of evolution to kind of, I don't know, feel good about ourselves and convince ourselves that we understand how the world works and maybe create a safe version of the world in which we feel safer and something that more in this very kind of cold and unpredictable universe. So right now in the course of the technological process where things are heading, they're heading by, I think, our ultimate desires. Like things in the civilization move. This is like discovered preferences. We can say all the things that we want, that we like to be, I don't know, one with nature and have very kind of natural things, but then the things that actually happen show that no, we want to have more and more like engineered stuff that's actually removing us from nature or elevating us above nature as much as possible. We want to have safety and security of housing, electricity. We want to go to other planets, and we want medicines. We actually don't want to be limited by nature. We don't want the diseases that nature brings. We don't want, decaying teeth, decaying vision. We all come up with actual unnatural mechanisms to fight what nature has in store for us. And death and disease is probably the biggest things that we are not not fans of, and that's why we've been working in medicine and biology and figuring out why death and disease happen to us, and trying to figure out how do we actually stay healthier and alive for longer. And ultimately, we'll figure it out how to completely take control of our biology and our destiny. And this is what humanity has been working on since the beginning of time. And this is actually what's driving us. This is the desire to be fully in control of our destiny. And we'll get there. The only question is, will we be alive to see that wonderful moment? Or maybe it'll be the future generations that get there, but humanity will get there.
I like that. I like that we'll get there. I hope that we'll get there in our lifetime. I would like to see that
Yeah,
happen.
well, I mean, provided there's no nuclear war and some other sort of calamity that
Stay
humans
optimistic.
with our ape-like emotions sometimes can actually be uh, driven to really silly decisions rather than smarter ones. But yeah, pending, the negative stuff doesn't happen, I think humanity will eventually get to a very, very advanced stage.
Yes, let's talk about your company because I know you have a very different approach to how things are done in the industry usually. So yes, give us some
Oh,
insight on that.
I wouldn't, yeah, I wouldn't say it's very different. I mean, we're a small virtual company, which for biotech is actually the norm, I think, these days, like early stage biotech, because you no longer need to like invest a lot upfront into like lab space or some other infrastructure. You can actually outsource all of those things, and so you can actually be much more capital efficient. And so for yeah. like a much lower amount of money, you can get so far than before, where you actually had to put a lot of upfront into building your own lab, hiring your own scientists, and then of course keeping them on staff for the duration of all the experiments that you need to do. So the upfront costs and the barriers to entry before in biotech were really high, versus now with the kind of outsourcing model, they're much lower. And so we've been from the very beginning embracing this model of just putting as much of our funding into R&D rather than the overhead. And so from day one, we've been operating as a virtual company with the research that we, well, I wouldn't even say outsource, because we actually collaborate with academic labs who are already doing what the type of research that we want to do. So we just teamed up with, for example, with Alejandro Campo, who was the pioneer of partial reprogramming, because we had very similar vision of how reprogramming needs to be translated, this tissue-specific approach that I mentioned. And so in the context of the brain, this was the approach that both myself and Alejandro were thinking about when trying to see if partial reprogramming can be effective at preventing cognitive decline in old animals. And so we teamed up to carry out these studies in mice that his lab carried out for us. And so similar models we used for Alzheimer's research. And so this is basically at this point now that we've conducted Alzheimer's research in the Alzheimer's mouse model and we got positive results, the next step is then to take this to the clinical trial stage. For that, we need to conduct IND-enabling studies. We can also do that using CROs. And so this is the next two milestones that we plan to hit. Yeah, in terms of, the company, this is what the company is focused on, getting Alzheimer's clinical trial.
What's the challenge of running a biotech company? Is it funding? Is it, I don't know, actually, I don't know anything about the industry.
Well, I mean, I think different founders have different challenges in biotech. I guess funding for us is one of the bigger challenges. Some biotech companies, longevity companies like Altos Labs might have fewer problems with funding, or New Limit or Retro, who have been, I think, blessed with funding kind of upfront. It's like the funding found them, you could say. Other companies actually, like if you need to go out and raise the funding for each next milestone, especially in this space as partial reprogramming, where you got a lot of big, well-funded players, I think that could be a little more challenging. Other than that, I think the biggest problem or the biggest challenge for any biotech company is the inherent risk, scientific risk, because you're never guaranteed that your therapy will succeed, or basically it can fail at any stage of development. It can be very promising at one stage, but then you get a safety issue that kind of forces you to go back to the drawing board, or vice versa. And I think the inherent scientific risk, and there's just no guarantees, versus, I don't know, IT, where it's really about execution. If you got your product market fit, it's just about execution and just basically growing the company. Execution risk, I think, is a much smaller problem in biotech than scientific risk or some other risks. Regulatory risk, there's a lot of regulation from different countries have their different regulatory systems, but at the same time, I think it's a very rewarding field, because you're potentially working on something that can make a difference to millions of people and actually decrease that sum total of human suffering that is kind of so high right now from Alzheimer's disease or aging in general. So I think from that standpoint, it's a very, I think, emotionally uplifting field to be working in.
I bet it's impact, right? Because
Yeah, absolutely. Yeah, it's one of the kind of the first impact investing fields, right? Biotech, because you are investing not just to make money, but also potentially to improve people's lives.
It's because even a step before reversing aging, which is a massive milestone, giving somebody with Alzheimer's 1 year, 5 years, 10 years more to spend with their families, to deal with the reality, to just have quality of life, is already an impact on an immense number of people. It would be amazing just to see that happen, not even before curing it, just giving quality of life to those patients in terms of years instead of months or weeks.
Absolutely. Yeah. Yeah. That's why we fight.
I like that. Listen, tell us more
Yeah.
about drastic science.
Oh wow. Yeah, that's quite a switch. Quite a switch from yeah, drug development and fighting aging to COVID origins. So drastic science is one of the two lineages of this drastic group that formed early in after the pandemic, basically trying to investigate the origin of COVID. And the drastic group from the very beginning was more leaning towards the lab leak side of the origin of COVID rather than just a random natural spillover that just happened to occur next to this lab in Wuhan. So yeah, it's been, I guess, 4 years now. Yeah. Wow, almost five. Soon it'll be 5 years of looking into the origins of COVID and kind of not accepting the natural explanation, the natural hypothesis of COVID, and being convinced, initially at least, that it's not a crazy conspiracy to think that it could have been a lab leak, then proving that it's kind of fighting back all the media and all the prejudice that surrounded the lab leak hypothesis, and finally elevating it to the status that it's a valid hypothesis that should be looked at on par with any other hypothesis, the natural hypothesis, that there's nothing crazy, nothing conspiratorial, nothing racist or xenophobic about suggesting that it could have been a lab leak, could have been an accident that led to COVID. So
If this was 2021, just saying this,
2020.
but if this was 2020 or 2021, just saying this on the recording would have probably forced me to cut it because it would have gotten deplatformed
Oh, you mean if now,
yes,
yeah, if
if
it's
now was
2021 right
2021,
now,
we
yeah.
gotten deplatformed just for saying this and probably taken off.
You're like, yeah, cut.
Did you face any of that? Any censorship,
Oh
massive?
yeah, absolutely. Yeah, all sorts of name calling and yeah, it's so ridiculous the accusations I heard just because I thought the lab leak was a plausible hypothesis. Um, yeah, and definitely a lot of censorship early on, and kind of well, like not deplatforming. I forgot the exact term. Like on Twitter, you were kind of clawed back. Your engagements were
Hmm.
shadow banned or
Shadow ban.
whatever.
Yes.
Yeah, yeah. So yeah, de-optimized. I forgot the term, but
Deboosted. It's
basically like
deboosted on Twitter.
deboot. Yeah, exactly. Yeah, that's the word. And basically, then after Elon bought Twitter, it came out that they had all sorts of algorithms that to actually actively demote anything that has to do with the lab leak hypothesis.
Where are these
So
detractors now, though? Because the lab leak hypothesis became it's now a normal narrative. It's accepted.
I would say, yeah, it's the prevailing hypothesis. I think it's just a minority of kind of virologists that are clinging to this completely unproven claim that it's been a natural double spillover in the Wuhan market, that by now it's actually been shown that this concept of double spillover was based on flawed modeling and flawed science. But somehow, I think for some reason in some of the virology circles, it still remains. I don't want to get into like the motivations of people, but I think we are all to some degree biased in kind of maybe somewhat tribal people, that if you feel that your field is at risk, or the entire field is at risk, or your particular subfield within virology, coronavirology, is at risk of even being viewed as the kind of the reason for the pandemic, you tend to maybe kind of close up and have a very defensive mindset. But other than that, I think in the general public or the general even scientific community, I think the lab-leak hypothesis is viewed as the more plausible explanation for why the outbreak of this very specific virus with a very specific feature that the lab in Wuhan set out to actually search and engineer this very specific feature occurred near that very lab just like a year and a half after the lab decided to engineer this very specific feature. And this very specific feature hasn't been found anywhere in any virus ever since. The SARS-like virus hasn't been found since or before the pandemic. So I think it's just the best explanation that it's that research that this lab was planning to undertake that led to this very similar virus to the one they described in that proposal actually leaking out of the lab.
Would you be willing, because we have a common friend who's also very interested in the topic of COVID. Would you be willing to do a podcast episode just around that thing?
Yeah, for sure. Yeah, absolutely. I did quite a few podcasts on the topic as well in my day. Happy to revisit it. I actually, wrote two very lengthy articles on the latest evidence for the lab-leak hypothesis back a few months ago. And basically, I think one of the novel aspects of this was the testimony of Dr. Ralph Baric, who was, of course, the premier coronavirologist, and he was a close collaborator with both the Wuhan Institute of Virology and this EcoHealth Alliance, which was the group that authored this proposal, this diffuse proposal, co-authored with Wuhan Institute of Virology, with Ralph Baric, in which they described this idea to engineer these novel furin cleavage sites in SARS-like viruses. And then Dr. Baric testified recently that the inspiration for doing so was this particular another coronavirus called feline coronavirus or feline infectious peritonitis virus, in which this acquisition of the furin cleavage site, or actually its mutation of furin cleavage site, can mean a difference between a rather benign virus and a highly pathological virus. And so it's very, very interesting to kind of see in retrospect the reasons for why they wanted to do this, and also the fact that this particular furin cleavage site in SARS-CoV-2, the virus that causes COVID, is exactly the same as the furin cleavage site in one of the lethal strains of this feline coronavirus. And this is very, very interesting to see that now that one of the reasons for why somebody might have wanted to put in a furin cleavage site in the SARS-like virus was this dynamic in feline viruses. And then you have exactly the same furin cleavage site between the two viruses. And then, of course, Ralph Baric saying that one of the inspirations for wanting to create furin cleavage sites or look into furin cleavage sites was this interplay in furin cleavage sites in feline coronaviruses. So,
It's going to be an interesting episode then. We need to make that happen. I mean, I hope it will happen, but I don't think in 2024 that will happen. One thing I wanted to ask you about is I've been made aware, but by our friends, of the correlation between COVID and Alzheimer's.
Yeah, it's definitely, I've seen some results in the press that say there's an increased association, not just Alzheimer's, all sorts of negative health outcomes that prior COVID increases your cardiovascular risk, your cancer risk, your dementia risk, including Alzheimer's. Yeah, definitely. Yeah, COVID is, and these so-called long COVID patients have even greater risk. Basically, yeah, it's a nasty virus, and it definitely has a lot of it has some aspects of neuroinvasiveness. Basically, it can actually infect some of the brain cells, or at least some aspects of cognition can be worsened as a result of COVID. And early on, people thought basically the loss of smell could have something to do with COVID infecting some of the brain cells responsible for the sense of smell, or some progenitor cells. So there's a lot of nasty things that this coronavirus can cause.
Why is it so nasty in comparison to other viruses? Was it engineered that way? Was that unintended in the process of
It's
mm,
actually, yeah, well,
killing?
it's not, yeah, sorry. Yeah, it's not necessarily like different from other coronaviruses. There's some coronaviruses that also have this neuroinvasive component. And actually, coming back to this furin cleavage site difference, there's some strains of coronaviruses that, like, the difference in their furin cleavage site, like, there's some furin cleavage sites that are better cleaved and some that are worse cleaved, like some more optimal and less optimal. And this could be the difference between a really neuroinvasive strain of the virus and a less neuroinvasive strain of the virus. And so it's actually interesting that the furin cleavage site could be one of the reasons in the SARS-CoV-2 virus, could be one of the reasons for neuroinvasiveness. And this actually, comes back to one of the early experiments in China that they did in 2019 in Beijing in the chicken virus, the IBV, infectious bronchitis virus, in which they actually engineered a novel furin cleavage site and then reported that increased neuroinvasiveness, greatly increased the neuroinvasiveness of that strain of the virus. So this again could actually come back to this very central aspect of this virus, this furin cleavage site, this novel furin cleavage site that no SARS-like virus has been observed with before or since, that could be driving some of the neuroinvasiveness or neurological pathology that we see with COVID.
Concerning, especially given
Yeah,
that it's not gone. People keep getting.
concerning as Elon would say. Yeah,
Yes, true.
yeah, definitely. His
Yes,
favorite
it's people keep getting it, right? So
concern.
it's not like we had it once and it's gone. It's still there, and it means more and more people getting put at risk of long-term pathology.
Yeah, it definitely has gotten much milder, thankfully. But it's yeah, it's still circulating and you get these waves and who knows. I mean, we might be stuck with it forever. Like it just becomes one of the seasonal viruses, like as other coronaviruses are like circulating, that we just get periodically infected with, and who knows how that can affect like serial infection with different strains of SARS-CoV-2, what it can do like long term. Nothing positive. Like basically the question is how bad can it get? And I guess we'll find out. Yeah, it's the question is, will we have these brain uploading technology before we're all like much dumber due to like serial infections by COVID?
Want to say exactly that? Like,
So
it's
hurry up,
pointing-
Elon. We need Neuralink to
we will.
save and not become this kind of idiocracy as this movie, predicted.
Yes, that's what I wanted to say. Is probably we will find out what the long-term effects of the real long-term effects are, and it's inevitable. So let's
Maybe
hope that we
we're
have.
already, like it's, the selection cycle is already kind of the result of maybe overall people getting a little less smart because of COVID. Who knows? I guess we'll see. The
Yes, that's
world
a
in
hot
general.
topic right now, and that's another thing we could do like 4 hours on, and that would get the podcast canceled definitely.
Yeah, there's a lot of dangerous topics these days. Not dangerous, but like people have very strong feelings about and could definitely get you deplatformed off some services.
Let's talk about getting tribal about topics. That's one of those that gets people really riled up.
And I know, and it's in general, this is a general trend that I think like people weren't as tribalistic before the pandemic. It's just something that I think, yeah, I don't know, like 2020, 2021, people have been much more polarized and much more aggressive and just in general, yeah, very hot-tempered. I don't know, is it the general trend in the world or is it consequence of people being locked down for months at a time or being infected with COVID or everything? I don't know. Like wars have started and this world is like take me back to 2019. We need a time machine.
I remember this super optimistic opinion piece by somebody, I think it was in Italy at some point at the beginning of the pandemic, that said maybe this is a good thing that will drive us closer to each other. And if you read that now, it's funny.
Yeah, yeah. Unfortunately, some of the only the worst prognosis have materialized. Yeah.
Yes. Listen, Yuri, I kept you here for almost 2 hours. So,
Hey, it was a pleasure. It was a
you have
fun
anything to add
conversation.
before we wrap up the show?
Mm, Nothing comes to mind. So yeah, thanks a lot for the invitation and this very stimulating conversation. So that was a pleasure.
My pleasure. Where can people find more about you, about your companies, about Drastic, which we'll talk about more in that other podcast?
Yeah, I mean, pretty much online. So use bios. Yeah, just I guess if you Google use bio therapeutics or I'm on Twitter, like a lot of the interactions that I do on Twitter and LinkedIn for more professional stuff. And yeah, and
Great.
Drastic, yeah, drasticscience.org is the website for our lineage of Drastic.
Great. You heard the people. Find him on Twitter, LinkedIn, find the websites. Everything will be in the description of the show, both in all on all platforms. Thank you, people, for listening to this show. It was a great episode. I hope you learned something. I definitely did. Remember, hit the like button, share the show, follow it on the audio-based platforms. And Yuri, thanks for being here again. I really appreciated your time and thanks for the knowledge.
Thank you. My pleasure.
People, this was the Tech of Tomorrow podcast with Sebastian Hidalgo. See you in the next episode.